Hey, hope you guys can hear me. My name is Joe, Joe Vigil. That's how you pronounce that last name. And I wanted to tell you guys briefly, the overview of today is I have stuff that's on the slides, but I don't have to go by the stuff that's on the slides. Many of you have already been dealing with disability for a while, and it's really meant to be kind of a introductory primer course for folks who are taking care of people with disabilities. If you're not used to that, if you don't know what all of those little things mean, it's a good place for you to be asking questions. And what I'm going to do is I'm going to assume you don't know anything. So if what I say is something you already know, that's fine. I expect that. Many of you probably know 80% of the information I have in the PowerPoint. The other thing I really want to do is open up the floor for a lot of questions, any kind of concerns that you have, things that you've been thinking about, decisions that you've been struggling with, related to the topics that I'll cover. Hi, welcome. You haven't missed anything. I'm just getting started. I really want it to be a place where we can have like an open discussion. The presentation, I can whip through it in 20 minutes, not when we have, I think, 75 minutes allotted. So there's a lot of time for questions and answers. But let me first tell you who I am. Like I said, my name is Joe, and the reason why I'm associated with the BDSRA is because my baby had CLN2. So we were diagnosed in February of '08. And my daughter passed away in February of 15. So it's been a few years. It's been over 9 years now. Professionally, however, what I do is I'm what's called a rehab psychologist. I don't know if any of you know much about the field of psychology, but within the field, there's various little aspects of it that we focus in on different things. So I'm a psychologist by training, and all that implies, but I don't really practice much mental health. I don't address mental health. In session, I'm not discussing mental health. Most of what I do is take care of people with catastrophic injuries. I work for the VA, so most of my patients are or were high-functioning adults at one point, very independent. But because of spinal cord injuries, brain injuries, amputations, burns, neurodegenerative disorders, strokes, those are kind of the population that I work with. And I end up doing what you guys would probably label as case management. It's kind of case managey stuff. I want to make sure that they're sticking to their rehab plans. And I end up doing a lot of assessment. All of my residents and I, we do a lot of assessment. We do a lot of working in interdisciplinary teams, making sure that families understand why we ask them to do certain things and why why it has all these goals on their rehab plan. And if they vary from that, then I kind of problem solve. I figure out why. What's the reason? 80% of the time it's because they don't understand why. They don't know why they're doing things. Sometimes it's a motivational issue. They don't feel like doing it. They're getting tired of doing it. They say, screw it. Other times it's a mental health problem, and I can hopefully treat things at my level. They don't need significant mental health intervention, and I can just kind of do a few things with them. But if they need more, I can make those appropriate referrals, do assessments if I have to. Sometimes it's a logistical issue. It's a family issue. They're not meeting their rehab goals for very, very good reasons. But I have to figure that out because it's affecting the patient care. So I have to figure out why that is. And I can give you some examples as we go. But what I want to do today is really kind of know who I'm talking to, but I want to kind of take you through, like I said, the very basics of what it means to take care of somebody with a disability and what you, as caregivers, I presume you're all caregivers, what you guys end up doing and the huge roles that you end up filling. You don't need to be a trained professional. Parents are a very quick study. You guys have to be. So again, a lot of what I'm going to tell you might be redundant. You might already know some of this stuff, but I want to make sure you understand why, and I want to give you a space to ask questions, to answer any questions that you have, and to help you think through some of the decisions that you'll make. Like, for example, do I keep my child in school, for example? Huge questions. So anyway, who am I talking to? Tell me a little bit about what's your name and which CLN2 type.
Stephen, out of Iowa, CLN3.
Okay. All right.
Wes and Melissa, our daughter, has CLN5.
CLN5, okay.
And my name's Michaela, and I'm a case manager in Omaha for some patients with CLN2 and CLN3.
Okay, welcome. Thank you for being here.
Anthony and Kelsey, CLN2.
CLN2, okay.
Jared and Tanya, CLN2.
CLN2. Okay, which lab are you with? Okay. Okay. Cool. Well, welcome. Thank you for attending our conference. So, like I said, when Batten disease strikes, when it hits, most people have no idea what to do. They have no idea what Batten disease is. You learn that very quickly. You ask a lot of questions. You do a lot of things on the front end. And when you're doing that, what you're really doing is case management. And so what I've tried to put together is a silly PowerPoint presentation, which is a quick guide for what we call service coordinators. And service coordination is what we, in the literature, in rehabilitation psychology literature and in rehab counseling literature, this is what we call case management, essentially. And it's just a fancy word for that. And the answer is there is no step one and there is no shortcuts. Bottom line, you guys have to know from the beginning that there is no shortcuts. And unfortunately, no two cases are the same. Even with the same type, there's huge variability in terms of responsiveness to medications, which physicians you need to see at which time, the level of knowledge with each physician, the level of knowledge that your physician needs to have, which frankly is not much. I'll explain that later. And we'll go from there. But you have to start from the beginning, essentially. And like I said, service coordination is really just a fancy name for case management. That's all it is. But it includes assessment, establishment of some type of a care plan, both a long-term and a short-term, coordination of activities related to this care plan. How are we going to implement those things? Documentation, very important, and referrals to community resources. This is, at its basic, what case managers do. You know, I'm oversimplifying things a bit. As a case manager, would you add anything to that roughly?
No.
I mean, that's pretty much the basic. Heavy on the documentation, huh? Those of us who work in the field, the documentation is pretty brutal. But this essentially is what you guys are doing as caregivers. And it's important for you to know that all of that is what you're doing every day also, including assessment. So you think assessment, well, that includes taking him to a doctor, doing an EEG, doing all of these imaging. Yeah, that's part of a professional assessment. But every day when you walk into the room, you can look at your child and know if something's right or wrong. That's assessment. Back when I worked in residential care facilities, and I used to work with folks with developmental disorders and other types of lysosomal storage disorders, by the way. In another life, I used to do that before I went to work at the VA hospital. But I worked with other, like Niemann-Pick's, Gaucher's disease, Fabre's, MPS1, Tay-Sachs. All of those people were on my caseload at one time. So I kind of had an idea of what a lysosomal storage disorder was by classification. But when it all comes down to this, I don't know squat about that particular patient. But once I get to know him, the moment I walked onto my home, my unit, I could say something's not right with Michael. Something's up. I don't know what, but I'm going to figure out something. That's assessment. That's what you're doing. This is why, as professionals, I rely so heavily on the caregivers and on the professional staff, and why decisions that I make surround that. For example, my daughter was in school all the way to the very end. One of the reasons is because she had a caregiver with her who had been with her for 6 years. She spent more time with my kid than I did. I mean, I could even say not too many people knew my kid better than she did, myself included. I mean, if something's not right, she's going to call and tell me something's up. That's assessment. So anyway, this is what I mean by service coordination and care management. All of that is you. This is what you're doing. Now let's talk about some necessary goals for Batten patients. What are we doing when you are diagnosed with Batten disease? One of the first things we want to do is maintain skill. Maintain what those skills are. Whatever skill the patient presents with, we want to make sure they keep that skill as long as possible. Every skill, not just physical, but also cognitive, emotional. All of those things are skills-based that they retain. Prevention is really key, all right? So let me tell you, 95% of my job is prevention. 95% of your job as caregivers is prevention. This is what we're doing. I'm going to go through the actual disciplines, but what you'll notice is this theme of prevention as I go through them. This is what each of these disciplines are designed to do. This is what we want your Batten patient to continue to have as much as possible, but in order for that to happen, we can't knock them down. If they have something happen and they have a hospitalization, for example, that can knock them down several pegs, and we don't want that. We want that maintenance of skill, but sometimes a big event like a hospitalization, a sickness, a pneumonia, a fall, a fracture, those kind of things can really set rehab goals back, so to speak. So prevention becomes very key. Stimulation is very important. This is, frankly, one of the main reasons my kid stayed in school the whole time. They can stimulate her in ways that I am completely incapable of doing, between the resources, the people, the activities, the field trips, the classroom. All of that stuff is stuff that I didn't have in my house. But that was one of the decisions that we made as a family to keep her in school. But stimulation becomes very, very important. Safety, of course, is kind of utmost. It all surrounds safety, whether it's ambulation, whether it's medications, medication administration, whether it's feeding, all of those things. Our top goal is always safety, and it is with you guys too. Every now and then, parents want to push a little too hard, and I was guilty of this. I knew enough to be dangerous, and sometimes safety, you kind of have to walk that line kind of closely. Like, for example, when I was putting her through walking and exercise programs, thankfully nothing ever happened, but you know, we were constantly considering her safety when we were going through that. Comfort also becomes paramount, whether it's comfort in a chair, comfort in a bed, physical comfort, but also emotional comfort. Who are they around? Are they around new people? Are they around people that they used to like to be around? My kid, even when she stopped being able to run around, she loved to sit there and watch the other kids play. It didn't bother her that she couldn't. She loved it. She would love to go to playgrounds and giggle and laugh, and that was really important to her. But you know those things. You know what your kid likes. Nobody else knows those things. So again, you would know what their emotional and physical comfort is at that point. Keeping our Batten babies happy is also, I don't want you to forget that. I don't want service coordination to take on a bigger role than it's already going to. I always want you guys to have a quality of life. I always want your babies to have a quality of life. And so every decision you make, I don't want you to forget that. I don't want you to forget quality of life of the baby and the family, which is huge. That's a big responsibility. But there always has to be that consideration. Without that consideration, sometimes we find ourselves just kind of falling into the routine of getting through the day. And let me tell you, over time, that's gonna That's going to hurt the caregiver. It's going to hurt the family system. So that's why we kind of really emphasize that. I always include that on all of my plans. What are you doing for fun? And I want you guys to consider that too. Really necessary goals. Fun. So if you guys aren't having fun, what kind of quality of life do we have? Right? Quality of life should be a major consideration. I always want you to consider quality of life. Why do we have wheelchairs, wheelchair accessible vans? Why do we have all of these seating systems? Why do we have alternate seating systems? Why do we have all of that? To maintain safety and comfort outside the home. I want you guys to always have a life outside of the home. For very good reasons, some people they end up relegating themselves to their homes. I understand all of that. Those decisions should be almost the exception, though. Remember why we have all of this equipment. Why do we have all of this stuff that is prescribed? All of the prompts, all of the different things that we have on the chairs, all the ramps, all of this stuff is to continue to have your quality of life. Even if your activities look a little different than you might have imagined, I don't want you to ever forget quality of life. And so you're going to hear me harp on that quite a bit today. And tomorrow I do a lecture specifically designed for the caregivers. And that's when I get a little meaner. I definitely do a little bit more patting on the back, a little hard enough and low enough if I have to. But you guys are kind of the backbone of what keeps all of this alive. So without your quality of life happening, without you getting the oxygen you need, so to speak, we're all screwed. Everything's going to go off the rails. So quality of life becomes of utmost importance as well. Like I said, happiness and fulfillment of unaffected family members becomes something that we always want to consider. Personal needs. I'm looking at several couples in the audience. There's personal needs. There's personal relationships. There's romantic, intimate relationships. Those things are going to have barriers put in the way. We have to figure out how to remove those barriers. Because again, without you guys intact, working as a unit, it's hard enough as a couple. And then if you have a single parent caregiver, everything is that much harder. Trust me. Because you're doing everything. You end up doing everything by yourself. So as a couple, as a family unit, we end up spending some time talking about that as well. We want to make sure you guys as a couple are fulfilled, are happy. And we never want you to lose sight on that. Okay? And I can answer lots of questions around that later, but I really want to make sure that we're focused in on that as well. I haven't forgotten about it. It's very, very important. Givens. Let's talk about a few givens. Let me whip through this. Okay. You guys are going to serve as advocates. Goes without saying. You're going to want to ask as many questions and get straight in your mind and seek clarification on and from other parents, other caregivers, physicians, other case managers, other service coordinators. I'm going to keep pointing at her and putting her on the spot because she does it professionally. She does it much more than I do probably. From allied health providers, from schools, you're going to need all of this information as you're making your decisions. And these are givens. This is obvious stuff, right? You're already doing this. So let's zero in on a couple of these things that are big. What about school? Do we use school resources or not? That's the question. That's a big question, right? So you guys tell me, are you guys using school resources still? Yes, 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 everybody? Excellent. Okay, good. Problems. Have problems come up? No? Good. Very relieving. We had minimal problems. Had I lived 5 minutes on the other side of the road and my kid would have gone to a different school, I would have likely have had a lot of problems. And that's just within my section of my parish. We call them parishes in Louisiana, not counties. In my parish, that's just in that section, huge variability. not just with the parish school system, with the school, with the principal, with the individual caregiver that's actually whittled down, who's actually laying hands and touching your kid all day, every day. Do they have one-on-ones? Do they not? You know, all of those questions. Those are things that, as a parent, you need to know. You need to understand that. You also need to understand, is it necessary? Some parents think certain things, and they really don't know what they need. For example, one-on-one. I've had some conversations with Batten parents saying, my kid needs a one-on-one. They don't have a one-on-one, I'm not going to put them in school. I'm like, well, my kid never had a one-on-one. Really? No. She had the same person that was assigned to her the whole time, but technically, because of class ratios, she didn't have a one-on-one. So I would have pulled her out of school based on your requirement. She got all the care she needed. She was fine. You know, but I also had to be comfortable with that. I had to have that explained to me, so you need to have that explained to you, just as an example, right? But school becomes a huge resource that I want people to consider. Some parents have come to conference before and said, I'm not going to have my kid in school. I'm not going to pull them. I'm going to pull them right away. They're out of school. And I want you to, rather than having such a reaction, I want you to really think about that as to whether that works for your child, for you. It's a huge resource, and I think it's something that should always be considered. I can't say it's right for everybody. Of course, you never know what resources your areas have. But it's certainly something that you have to ask. You have to ask about the reliability of staff, the reliability of their support systems that are around, their therapies, their dietitians, their nurses, who's at the school. All of those things become very important. Variability in the available resources, which I already mentioned, depending on the school district, where you are, rural versus city, you know, resources can vary broadly. Dependability of the individuals. It took us a couple years to find a really good caregiver for her. We called them a paraprofessional. For us to find the right para for my daughter. And once we did, it stuck, and it was a wonderful relationship. But some of the other ones, not so much at first. There was a few growing pains there. Various levels of skill among providers. We had a physical therapist, for example, who kept thinking that my kid was having seizures all day and kept wanting to administer rescue medications. And I was like, nope, she's not having seizure. She has what's called a progressive myoclonic epilepsy, CLN2. And so that's not a seizure. So it took us a little while to kind of educate her and figure that out, but we were able to do it. Family. Do I leave my kid with family? Do I not leave my kid with family? Same questions, right? You see the theme here. All of these become questions that you have to start really weighing. And I say start because I know you're already doing it. I say start with other things in mind now, with quality of life in mind now. Because let me tell you, nobody is going to tuck your kid in like you tuck your kid in. Nobody. I had a little routine. I would tuck my kid in, and I would roll her up like a burrito, and I would put things between her knees and put a pillow behind her back and bunch up the pillow and put this underneath her neck so her neck was supported. She was perfectly positioned like she should be. And she would jerk and get out of position, but that's where nobody tucked her in like daddy. But I still needed to take my wife out to dinner, Mardi Gras balls. I still needed to do those things. And when I got home, she wasn't in a good position. But it was okay. That's okay. She lived. She was fine. I just put her in the position a few hours later. But I had to weigh out quality of life versus my available resources, who I trusted to give medications, who I trusted to tell me if something was cooking, if something doesn't look right, people that are familiar with her. I can't just hire her paraprofessional all day, every day, you know? So that was just some of my decision-making process related to that. Now, not to sound too eggheady, but there is all kinds of literature on this. One of the biggest researchers in this area is a guy by the name of Reisberg. And the reason I introduced this to you is just there's different levels of dependencies and models of dependency. And this particular one talks about cognition. So on a cognitive level, at what stage is your loved one? And what he does is he talks about this from a cognitive perspective, but he also talks about things from a feeding perspective, nutrition perspective, seizures, neurological disorders, internal medicine issues, mood issues, impact on families. And this is what you're doing as part of your assessments every day. I think it's a good way of kind of thinking about these things. In all of these different areas, you're making assessments, you're making decisions in all of these different areas, just like Reisberg would do, just not in a pretty little sheet and like we would do as case managers in each of these assessments and each of these things that we have all these instruments to assess this stuff. But you're doing this. This is what you're doing on a daily basis. So your child might be much more independent in one area and need a lot more support in other areas, for example. But this is what they're doing. This is when a case manager is assessing you and a rehab team is assessing you, this is what they're doing in each of these areas of life. Now, moving on, physiatry. Have y'all ever heard of that term, that area of medical specialty? You ever heard of physiatry? Okay. So don't be alarmed. Most med students have never heard of physiatry. Physiatry is its own area of medical specialty, okay? We refer to it in my department roughly as PM&R, physical medicine and rehabilitation. But that's what they are. They're physical medicine and rehabilitation physicians, and this is their specialty. And the reason why I like to involve them is because they are the experts at taking care of somebody with a disability. So let me say that again. Physiatrists are experts at taking care of somebody with a disability. Now, they do other things. A lot of physiatrists, frankly, are sports medicine docs, but they're rehab docs. They're not an orthopedic surgeon. You don't need to be a surgeon to do sports rehabilitation. How many people need surgeries? Not many. So they're the experts on everything else, on all the soft tissue stuff. If I needed a surgery, I would go to an orthopedic surgeon, but I don't need that stuff. I might have sprained my ankle and had a high-level grade 3 sprain. An ortho can direct you, but they're not the experts. They'll think they're the experts, by the way. There's some arrogance. But those of us in PM&R, they're the experts. I'm going to tell you, when my daughter broke her ankle, we consulted with ortho, and then I took her to PM&R. Because ankles and shoulders scare the hell out of me. She's an athlete, so that scared the hell out of me. And I followed that PM&R rehab plan specifically. But they're the experts on sports nutrition, on sports rehabilitation. They also do a lot of pain management now. A lot of our PM&R docs are starting to do pain specialties because it pays a lot. They do a lot of injections. But really, they're specialists in rehabilitation. They're the ones that do the injections on the elbows to prevent contractures and in the ankles. It's really PM&R docs that do that. They do that in my clinic all the time. Especially in our interdisciplinary clinic, they'll whip out a needle quickly and do it right there, under guided fluoroscopy or those kind of things. But physiatry is a resource I want you to be aware of. And I don't even know if your particular area has this, but they are one of the smallest areas of medicine. Very confusing to a lot of other people, even people who are in medicine. And it's usually acknowledged as kind of the leader of the comprehensive rehab team. So let me give you an example of what that looks like. The rehab team will go in, they will assess. The PM&R doc will say, I think they need a different seating system in their wheelchair. The PT says, okay, I'm going to measure, I'm going to do this, but because of this, they need different pressure on this IT and this and that. And so the PM&R doc says, okay, well, we'll get this pad instead of this pad. And they work together and they order the right thing. Ortho, pediatricians, neurologists, they don't know anything about what I just said. They said, what's the seating system? They don't know. They're not supposed to know. That's not their area of expertise. So what usually happens in kind of more rural areas is we ask the physical therapist about this type of stuff. We ask them, what do they need? but the physiatrists are often the one that writes the order. They'll tell you exactly what they need, and they can do tweaks to that order, you know. So if you need an AFO, for example, an ankle foot orthotic to keep things from flexing too much, well, then they can order the different type that you need. They can order ones to help that you wear when you're sleeping, some of which that can do what we call articulate. You can adjust them in the sleep to get a nice stretch when you're nice and relaxed. And again, prevention. We're trying to prevent things, prevent contractures, prevent pain, right? This is what we're doing. And they're the ones that know all those little nuances and know exactly what to order. Like I said, they guide, consult, and often direct physical therapy, occupational therapy, and speech therapy. So let's talk about some of these modalities. Physical therapist, referrals to PT usually come from other specialties. Nowadays, the PTs are starting to become their own independent practitioners. They can even order and direct treatment as they see fit. You don't need to go through a physician. So that's a good thing, at least in America. Many are now completely independent providers. In other countries, they often call them physiotherapists. And most people understand what a PT does. They stretch, they help range of motion, those kind of things. But in neurodegenerative conditions like Batten disease, they're going to maintain that strength. They're going to maintain endurance, coordination, flexibility, range of motion, and most importantly, I shouldn't have even said it last. I should have said it first and last, bone density. Bone density is something that we really focus in on with people with catastrophic injuries and people with significant disability, because that's where problems are going to start coming into. I can't tell you how many Batten kids that we go to move them and we bump a leg and it breaks a bone. You go to move them and they dislocate a hip. And most of the time it's because they haven't been doing things along the way to keep those things strong and to keep that flexibility from happening. But there's always exceptions. There's always injuries and accidents that happen. But for the most part, that's one of the best ways to reduce injuries is by helping with bone density, but also that range of motion. That's another big one. Our bodies are meant to move. Our body parts are meant to move. All of our body parts, not just part of them, all of them. Your back is meant to go in all directions, right? Not just supposed to sit there. So we have to move and get you to move around and do all that type of stuff. And that's what they do. They help you move to maintain that movement. And again, all in the area of reducing risk, reducing injury, reducing discomfort. And the other thing that gets me is contractures. Contractures, there should be very little reason why people develop contractures. They end up, you start tightening up, particularly in the latter stages of the disease, but just without movement, contractures, things kind of freeze up, things kind of need to be released, and contractures are often painful. So that's what I worry about. I worry about pain, discomfort. I worry about those types of things when we're dealing with that. There's different types of physical therapists. There's different types of specialties, and I work a lot with what we call our neuro PT with brain injury cases and those kind of things. But they have specific PTs that are specialized in pediatric disorders and pediatric neurologic disorders. So I was able to find one in my community. I had to look. I didn't know who they were. I had to look. But there were actually a couple. So I found one I liked, and we were able to stick with her to the bitter end. A couple more other things I want to mention about PTs is that they're often the one that really helps identify the majority of your durable medical equipment, okay? So if you hear the term DME, that's what that means. We throw that around for everything, from wheelchairs to van conversions to grab bars in your bathroom. That's all DME to us. But this is the type of stuff it includes, okay? So if you're not familiar with any of these things, or if you think you could benefit from it, ask. You might not have known some of these things exist. You know, ask about those things, even if it's for you to grab on and for you to have these assists for you to care for your loved one. All of these things are relevant. So this is an example of a walker, or what we call, the technical term for it is what is called a gait trainer. Now they make these for adults too. I have patients who use these. But this is what Mary Peyton's, this is my daughter, by the way. This is what hers used to look like. And I bring it up because as a parent and as a rehab specialist, I kick myself that I didn't get her this earlier. That was one of my biggest mistakes I think that I made, is I waited too long to get her one of these. She loved it. When I first put her in it, she was like a toddler in one of these things. You know how they have this walkers for toddlers? That's what she reminded me of. You couldn't stop her. She was all over the place. She absolutely loved the independence. But what I want to point out, I went beyond the speaker. Sorry about that. I told him I wasn't going to. But what I want to point out are the different prompts that are on that. So like this, she didn't have her saddle on it. There's an attachment that goes from back to front, that as she lost her coordination and her strength in her legs, she was able to sit down on that, and that really helped her to continue to use it. I want to show you this because these things are remarkable inventions. There's all kinds of modifications on there. Right then you can see she's holding on by her forearms and her hands. She was strapped in. She was strapped in at the waist and at the elbows. But as she progressed, we were able to continue to put more prompts on it and use these things. And she loved the mobility and the independence. Daddy, the rehab guy, I love the fact that we were getting some exercise. So we would go and do all kinds of exercise every afternoon. And you can see there she's also wearing AFOs, ankle foot orthoses, bilaterally. They're the hard ones. And the main reason you want to wear something like that is again, for safety. You want to prevent that ankle has a tendency to turn out. You look like you're going to twist your ankle, and some kids do. They can even break their ankle. So it just allows her to maintain that strength to be able to push off and use the rest of her muscles there. And it's a safety thing. I usually used regular shoes. I just bought wider shoes and regular shoes, took the insert out, and that's how she was able to use the AFOs, if y'all haven't done those yet. But again, fun. We had fun. I want you guys to always remember, have fun in everything you do. Even though this was physical therapy to her, it was our fun time. This was her time to have fun. And you can see there, she does have the saddle in its place. That's why I put the picture up, not just because she has a cute smile. But there's a little saddle that she had that we were using when I took this picture. So you could see what that actually looks like in its place. Family fun. We use this as our bike ride. This is my other daughter, who's now going to college this year. She'll be in college next month. So you can see that we would go on bike rides together. She loved to ride around on Mary Peyton's gait trainer, which was good for her. It gave her a little bit more strength to push off. So I want you guys to integrate as much of the family as you can in these activities. Even though it's physical therapy, it's supposed to be fun. We're supposed to be having fun with all this stuff. A group of teenagers in our area raised some money for Mary Peyton, and we're able to get an adaptive trike for her, all of which is adaptable. This is when Mary Peyton could still hold her head up, her neck up, all of those things. When she couldn't, we had prompts for all of that. So we still were in the bicycle. Now, she couldn't push it with her legs. She never could ride a bike. She never could operate one of those little electronic Jeeps that you get from Target either. She almost killed her sister several times back in the day. She had no concept of steering and gas. But these trikes gave us all kinds of mobility. And when you're moving, her legs move. So even though she's not moving, her legs are being moved. Range of motion, bone density, strength. And then after we got out of this, from when we finished our workouts, I would stretch her then with a nice warm muscle. It was able to stretch, and things were able to stretch a little bit more readily after all that. And in case you haven't seen different types of adaptive vans, again, I probably should have done this before. At the time, when we got the van, I was in the military, and I would go away on the weekends, and my wife couldn't get the wheelchair in and out of our big SUV. So we ended up getting an adaptive van, which I did not want. I had just paid for my other car. I drive my cars for 10 years. It really pissed me off. It cost me a lot of money, but I should have done it earlier. It was wonderful. It was awesome. Our insurance paid for the modification, but I had to pay for a new vehicle. They will only modify a vehicle that's either brand new or only a year or two old. So in case you have a van you're thinking of modifying, it needs to be low mileage or pretty new. I also recommend a rear entry van for a child. It takes up less space. You can seat more people. The side entry vans, you need to enter and you turn. It requires a bigger turning radius, so you're giving up some seating. But if it's an adult, makes sense, right? But as a child, we would put her back there. We would put her through, all the way through. That little box you see on the floor is what's called an easy lock system. It locks her into place, makes her real easy to get in and out. Never had to take her out of her chair. Did that, a couple of seat belts, boom, we were good to go. And that little ramp right there, I did not get the automatic ramp, the button push. That stuff breaks all the time. I got what's called the manual ramp, and my 4-year-old could do it. It's very light, very easy, easy peasy to do. Doesn't freeze up when it's cold, not that it's ever cold in Louisiana. But those things don't break. The manual ramps don't break, so highly recommend that. Do any of y'all have vans yet? I tell you what, it's such a wonderful invention. I mean, it was a godsend to us. Not just when I was there, it just made life a lot easier. So as you consider it and as you work the insurance process, if you guys ever want to do that, let me know. I'm happy to go down that path. This is some of the other adaptive equipment that we have. So the picture on the left actually shows 3 pieces of adaptive equipment. That's my wife sitting in a what we call a floor seater. That's called a special tomato chair. I did not like it. I do not recommend special tomato. I don't like the way it cups the kid. It should have been molded differently and maybe even individually modeled, but a lot of people use it and it cleans off really well. I will say that. My little one to the right is sitting in the wheelchair. Mary Peyton is in her stander. Have you guys ever heard of a stander? Do you know what a stander is? Strongly recommend standing as much as possible, as long as possible. She stood 2.5 hours a day, even until the day before she passed away. And her death, by the way, was very sudden. We didn't know anything was coming. It was very sudden. 2.5 hours a day in 2 shifts is when she would stand. And I used to call her my cow because she would sleep standing up. You can see on the right, she is sound asleep in that picture. She felt great when she got out of that chair. She would just go, oh, like you could see her body like relax, like, oh my God, this feels good. Thank you for getting me out of my chair. And my little daughter there loved for me to be strapped in so she could play video games. That's what she's doing. So a couple other modalities I can whip through quick. Occupational therapy. These are really our experts in what we call daily living. So bathing, dressing, going to the bathroom, feeding. These are our experts on this particular thing. And there are all kinds of gadgets that have come out over the last 5 years. And the only reason I know about them is because I'm still in rehab. I would have loved to have had some of these feeders and things that they use for people nowadays. Back when Mary Peyton was around, she could have independently have fed herself for much longer. We had adaptive spoons and built-up plates and all that stuff, but the OTs are really the experts on that. So if you can, if they're available in your area, keep them as part of your routine. But that's really what they're for, just in case y'all didn't know that. That's what they're for. They also have a lot of training in what we call cognitive and sensory rehabilitation. So if you have a stroke, I often send my patients to my OT who does cognitive rehabilitation with them. I know how to do some of it. She's the expert. She knows how to do it all. She's got all kinds of games and tricks and electronic stuff and things that they get them to do, stuff I would have never even thought of. They're experts in that. That's where you send somebody post-stroke, post-brain injury. Our kids are no different. They're needing that brain stimulation. They're needing all of that, particularly if they're engaged in any kind of therapeutic modality, like some of the gene therapies and things that are out. They need constant stimulation so that we can continue to regrow new cells. You need stimulation, right? That's how your brain develops, is through stimulation. And again, maintaining daily skills, all of that. They can also show you some different ways on how we want to approach a task. Even caregivers, they can show you different ways, like for example, a shower chairs or shower beds. There's all kinds of different ways you can go about in terms of moving your Batten baby around. And I was doing a lot of things wrong. You know, I work with adults. You know, I don't work with kids. I don't know squat about kids. So Mary Peyton taught me a lot. But they can always show you different ways of going about doing that stuff. Adaptive recommendations, including equipment. I relied heavily on my OT to recommend certain equipment and like trays that she needed when she was in school. I didn't know what to order. She did. So she would make recommendations and that kind of stuff. Very, very wealth of information there. Okay, do want to save a little bit of time for speech because it's not just about speech and getting rid of your lisp. Most people know that I used to work with a speech therapist back when I couldn't say my S's. But what speech therapists do with people with Batten disease is they really do a lot of stuff with feeding and swallowing. So in case you didn't know that, that to me is a very important aspect of what they do. And again, they're focused on safety, okay? So full disclosure, me and my speech therapist went rounds. She's the expert. I probably should have listened to her a little bit. I never got bit in the butt because of it. They are very conservative typically because they want to keep everybody safe. More power to them. And I highly recommend you listen to what they say. But I also, there's all kinds of different speech therapists. In my particular area, we actually had some in the greater New Orleans area that were actually board certified in behavioral analysts, specifically for CLN3 kids. Sometimes behavioral disorders can develop around feeding. You'd be surprised. For those of us who have the different types, it's not so much the same. But CLN3s, we've had a lot of issues around feeding. Sitting still, throwing food, you know, refusing food, you know, all those types of things. My kid couldn't refuse food. They can. And there are actually people that are board certified in behavioral analysis related to feeding disorders. So I never had to consult, but just know that they're out there if you need to. Respite care. I do want to at least tell you guys what that means. It can be provided, typically respite care is provided at home. We use facilities for respite care at the VA. Like we'll send patients for an annual evaluation at a spinal cord clinic, for example. And they'll be gone for 2, 3, 4 weeks at a time, which is respite care. It also gives everybody a chance to rest. It also makes sure that we're staying on track with their rehab plan, make sure we're doing everything appropriately. We have kids, so we don't really want to send them away, you know. Most respite care can be provided within the home. Sometimes it can be by a family member, a friend, a loved one. Some people even talk about having the parent serve as their caregiver, and in terms of reimbursement. Sometimes there's daycare facilities. When the school's not in session, I used to take my kid to a pediatric daycare that specialized in taking care of people with disabilities because I worked. My wife works. She wasn't a teacher. She wasn't off when Mary Peyton was off. So we had to take her to a pediatric daycare. So those things exist. And again, why am I talking about this? Because I want you guys to know your resources and use them if you have them. I want you guys to always have your time to catch your breath. Respite means rest, right? So let's rest. That's what it's for. It's for caregivers. It's for families to do this. I strongly encourage you to at least consider, but look into what your options are available. What does your insurance pay for? A lot of Medicaid and stuff pays a lot of money for this. So there's some resources typically that are out there, even if it's in home. Companion services, personal health care. Sometimes there'll be what we call PCAs, personal care attendants will come and maybe do some light housekeeping, maybe make some food, prepare food. Having an extra set of hands is what I call it. Having an extra set of hands around is invaluable. If you don't mind somebody in your home. My wife didn't like anybody in her home. So we relied a lot on grandparents. That's how we ended up doing things, but we did have this available to us. It just didn't work for us. And what I want you to know, let me stop before I go any further. Let me stop and say, do you guys have any questions about any of that? I've actually covered a lot of material, and I've been running my trap. So you guys talk to me. What questions do you have? Any of this new information for you other than the physiatry thing? No? Y'all got it squared away, huh?
There were some good ideas, though. We haven't looked into a gait trainer.
Yeah.
And then a stander.
Yeah. Now, we'll say it takes a while to get one. So I want you to order it as soon as possible. Ours either. Mostly because of the dogs. I keep saying as soon as my dog passes away, I'm going to rip up the carpet. But the carpet also helped Mary Peyton when she was walking and falling. You know, it had that little pad. But as soon as my big dog goes this time, I swear I'm gonna get regular floors. How many people have carpet anymore? I'm one of the few. Hi. Literally. Yeah, I don't like that answer. What I will say to that is, and what for those who couldn't hear what she said, she was asking about insurance reimbursement, turnaround, getting things ordered. They. So one reason I dealt with physiatry is they can do everything in one shop. When I was dealing with neurology, for example, before I got hooked up with physiatry, they didn't know what to order. They didn't know what to ask. They just kept sending it to PT. PT can't order that stuff, and so they would say, I need a doctor's order on this. They would send it to neurology, and then back and forth we went. So I finally said, what the hell am I doing? I know better than this. I'm a rehab guy, right? I'm supposed to know all this stuff. I couldn't find a pediatric rehab doc, though. So I was able to find one finally. We have one in my area, and I live in New Orleans. So keep that in mind. One, let me say that again, one pediatric rehab doc. There's a few residencies and stuff around, but for the most part, one works in my area. And I got in with him, and he ordered everything. I would go to him, and we had an hour-long appointment about once every 4 or 6 months. He's like, what do you need? I said, I need this, 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 and this. I would leave with a stack of orders, and it was done. And his office coordinated all of that. All of those letters to school, all of those things that say they need this and this and this, he handled all of that. Now, I'm giving him a lot of credit. I hope that other PM&Rs would do that, physiatrists would do that. But that's what their job is to coordinate all of that care. So theoretically, that's what they should be doing. You know, I've had a few bad experiences, but yes, ma'am. Definitely. Mm-hmm. That's unfortunately what happens, but you're in good company. I would almost expect problems like that to come. That's how common they are. Physiatrists should be able to cut out all the middlemen, should be able to. And again, coordinate care. They're the experts in service coordination related to people with disabilities. That's their job. And if they can't get exactly what they need, they can call really quick and get what they need. They can pick up the phone and say, look, what AFO do I need? Well, I don't know what to order. That PT says, good, this, that's articulating, blah, 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 boom. He goes in the catalog, he orders it, specific, puts the catalog number, sends it off. And most of them, frankly, are used to working with Medicaid because most of these kids get on Medicaid because of their disabilities. So they're pretty well versed in that, which I found very helpful. Medicaid to me was a new language outside of insurance, and everybody who works in disability seems to speak that language, which was helpful to me because I didn't know anything about it before then. Yep. Yep. Is it because of your state? So there's waivers. Every state has a different waiver system, however. So Louisiana, their waiver system was one that had I put her on that wait list, she would have been on it and beyond her life expectancy. It was a very long wait list. So I went to them, and I went to the office, and I sat down, and I said, this is my problem. What can you do? There's got to be a solution. You and I both know there's a solution. And if you're in the military, you know there's a solution to everything. You just got to know who to ask. Because if you're not asking the right person, they don't know squat. And then they won't do anything to help you either, which is aggravating. Customer service be damned. But I went to the Medicaid office, and she's like, oh, yeah, there's something called a Children's Choice Waiver. I said, what the hell is a Children's Choice Waiver? Never heard of this. And so what it was essentially she gets all the benefits of being on Medicaid, have a Medicaid card, except she has an account. And so there's a limit. And other states have this too. We just call it a children's choice. I don't know what your state would call it. But she essentially had an account. And she was able to, that account paid for everything until we hit that account, and then you're out. But it was a lot. It paid all of her medication, all of her diapers, all of her formula. The 1 year that it didn't was the first year we got on it, we got that van modification. And it paid about $15,000 toward the van modification. The whole modification was like 18 grand, so I had to come out of pocket a little bit with it. But it paid for it. And that was all her what's called her Children's Choice Waiver. And then after that was paid for, the next year, diapers, formula, medicines, all of that. Pros and cons. But for the most part, it saved a lot of money, frankly, but it also was very helpful. So there are what we call waivers of Medicaid. So make sure you're looking into that. Super helpful. As part of that requirement, you usually have a case manager that's assigned to you. So we had a case manager through Easter Seals. You might have heard of Easter Seals. She was very nice, useless protoplasm. She didn't help us at all. She was awful. Very nice, very sweet, very well-intentioned, didn't know what the hell she was doing. So again, variability in resources. But my wife is good about crossing T's and dotting I's, so we were able to navigate that system. But and she did that. So as a couple, you can kind of split responsibilities. She did that. I took her to the doctor's appointments. She did that. I took her to the doctor's appointments. I went to the IEP meetings. We split up. Tag team. Kept ourselves sane. Great question, though. What else? Did you just laugh? I would have just laughed. I mean, really? Okay, we'll like I was just telling him, you gotta ask the right person. Keep going. Don't give up. You and I both know that's not right. That's complete BS. They absolutely do some type of modification. You just haven't asked the right person. But somebody somewhere says, well, you have to meet this requirement. Check, check. And you don't, so I'm sorry. That's BS. People don't know what they're doing. Keep asking. Don't give up, though. And those things are expensive. Bath remodels are very expensive. So that's another big one that'll help pay for. You said a mouthful right there. You're absolutely, I would say 80, 90% of the injuries that we deal with in the rehab clinic happened in the bathroom. And that might even be low. Getting out of the tub, getting off and on the toilet, blah, blah, blah. You know, all of those things. It's a dangerous, slippery area. But it's tight, too. You know, you turn in a kid, bang a foot, you know, injuries can happen. Do you have a shower? Do you have a shower bed that you can put her in? So the shower beds are great. Some of them fold and contract to a seating position. Ours did not. It was flat. But we would put her on that and then wheel her into the bathroom. And we didn't have a modification. And we had a kind of a small bathroom. Her back bathroom was pretty tight. But my baby was pretty long, but she didn't weigh much, so it was easy to kind of get her. It looks like it looks like something you see out by a pool, like a lounge chair type of thing. Yes, but it's flat, and it was on wheels, and it adjusted in height. So we would take her out of her chair, put her on that, strap her in, wheel her in there, and then it would lower over a standard bathtub. We just had a standard bathtub in her bathroom. And again, now she was small, she didn't weigh much, but she was long. So the bed was a little long. And we had, of course, the handheld shower and all that, but it saved our backs, And as a former back patient, one of the things I could not do is lift out of the bathtub. It was too low. Oh, my dear. So unless I could put my foot in the bathtub physically and lift, I couldn't bend all the way down to my ankles and lift 70 pounds. That was too much even for me. And so ultimately, until we got that device, it was a challenge. But yeah, they make these little things. I should know the name of it, but it looks like a lounge chair. That's obviously all waterproof. The water goes right through it, blah, 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 blah. And they can just strap her in. I used to strap her little naked butt to it and put her in there, hose her down. I like to put her lower here into the water so she wouldn't get too cold. So we would fill up with warm bath and that kind of thing. Otherwise, she'd start shivering. But it would lower all the way down and then raise back up. It was a back saver. It was a back saver. I don't know what it's officially called. I should know that. Let me see what it. That one might. I don't know if that'll go over a tub. That particular one. Yeah, it doesn't look like it does. Ask an OT. So remember, OTs do all of your activities of daily living: bathing, dressing, toileting, feeding. OTs are the experts, and they'll give you the equipment that you need. They'll know exactly what you're talking about. And if it's a child, it's that much easier because it's smaller. You don't need one for an adult. Yes, ma'am. Resources might be different depending on what the diagnosis is and what's going on to how they're writing the order. So if they're writing the order for a home eval with brief follow-up, then that's why they're and to be honest with you, not all OTs or PTs know what the heck to do with our kids. And again, they're not specialists. Right. And so use them for what they are. Like, for example, I alluded to it earlier, and I just remembered I didn't go back to it. Physicians often are not the best resources because physicians are very smart and very good about what they know. But beyond that, they don't know squat. Now, that's not a bad thing because what you're paying them for is for their opinion on what they know. That also includes the biggest question I get asked are Batten disease specialists. And let me tell you, there really aren't any Batten disease specialists unless you live in Rochester or maybe a few other little areas now, like Ohio, those kind of things. You don't need a Batten disease specialist. You don't, I promise. Even if it's for seizures. The neurologist can handle the seizures. They can handle seizure types. They have no earthly idea what medications to use. You can come here and have some suggestions to run it by them, and I can tell you some really strong suggestions I have related to CLN2. I don't know about the other diseases, but the CLN2, we had her on a great plan. But It came from a neurologist that had never even seen a Batten patient, and we just sat down and we worked it out. But I used her for her expertise. I didn't have a Batten expert. Her expertise was what it is, pediatric epilepsy, including neurometabolic disorders. That was her specialty. She had never seen a Batten kid before. She didn't know there was a CLN2. She was like me. The only time I'd ever heard of Batten disease was CLN3. I didn't know there was 12 different types. I'd never heard of 12 different types. That particular doc was wonderful to work with. Now, not all of them are, but just remember, use them for what they are and get as much information from them as you can. So, okay, so what would you do? What about this? What about this? Ask those questions, write all that down, and then consult with other people and make a decision. I always consulted with at least a couple different providers before I made a decision. Like, for example, a medication. You know, I would usually hear the recommendation, ask another doc, maybe ask a pediatrician, pull the literature, and then make a decision. That was how I did it. And so for you guys, just ask. Ask lots of questions. Ask other parents. Ask parents that had good results. We enjoyed excellent seizure control to the end. When I took her to, she was in a gene therapy trial at Cornell. And they said, who is your neurologist? This is the greatest medication regimen we've seen. And I said, you're looking at it. You know, and it's not because I know squat about neurology. The neurologist was willing to work with me. I collected data for him. We worked it out, and we figured out this. Neither one of us knew what the hell we were doing, but we knew something was working. So we kept going down that path, and we figured it out. And it worked. It worked really well. She still had myoclonus. But I didn't want her to be in like a vegetative state either. Other kids, I've seen other kids here, no offense, but other kids were pretty zonked. And I wanted her to be a little bit more alert than that. And so it's kind of your decision. You have to weigh that. That's totally your decision. Wrapping up briefly, I want you to work with where you are. We all have different backgrounds. We all have different resources, and if you notice, this slide looks exactly like what the slide at the very beginning said about Givens. It's the exact same slide. Work with where you are and what you have. This is what your job is to do, and ask lots of questions, figure it out, and I'm sure with thought, with reflection, with meditation, with prayer, with consultation, you guys will make the right decisions. Sorry I couldn't cover everything, but I want you guys to feel free to reach out to me and my wife. If she hasn't, she was more of the paperwork person, so she would actually be better at answering those questions than I am. But this is our address. This is where we live. By the way, I'm happy to send you guys this PowerPoint. Just message me through the app or email me or text me, whatever you guys have to do. I'm happy to chat with you guys. Facebook's a great resource. It keeps us all in touch with one another. BDSRA is pretty active there. And the one final thought I want to leave you with, and I want you guys to always keep this in mind, has to do with quality of life. I always want you to remember that she was living with this disease, not dying from it. I always want you to remember to live. I always want you to remember to keep that quality of life, keep your family's goals in mind as you make these decisions. And you're not going to make a wrong decision. You're not. You're going to make the one that's best for you at the time with the information you have. We're going to second guess ourselves. We're going to Monday morning quarterback ourselves to death. But for the most part, I think you guys will make the right decision. Anything else? All right. Well, thank you all for coming. Thank you for your attention. I appreciate it. It's a pleasure to meet you guys, at least like this. I hope to meet you guys a little bit more throughout the conference. All right, give you guys a little bit of a break. I think the 3:30 sessions are still on track, right, Patrick? Thanks again, guys.